Good afternoon, ladies and gentlemen. This is Dr. James Lyons-Weiler coming to you live from the WWDNYK studios in Pittsburgh, Pennsylvania. This is the show Unbreaking Science, and today we're going to be discussing what else? Coronavirus. It seems like it's the only thing that anyone is doing anything about these days. But nevertheless, we have a very unique and eminently qualified guest with Dr. Meryl Nass here. She will be joining us shortly. And so I want you to be sure that you have a moment to share this broadcast and tag a friend on Facebook or on retweet it. Or if you're on other social media outlets, please be sure to share everything that you can about this. And let's get the discussion going. Welcome to Unbreaking Science, Meryl Nass. How are you?
Hey, thanks for inviting me.
All right. Well, you're an eminently qualified internal medicine, board certified. You've been involved. I've read your bio. You've been involved in, and we met in Maine actually, but you've been involved in helping to shape national policy in response to epidemics for quite some time and outbreaks quite some time. And so I'm really honored to have you here to discuss these issues.
I appreciate that introduction. I'm not sure that I've attempted to affect policy, but I'm not sure that I have.
Yeah. Well, let's talk about coronavirus, specifically the issue that you brought up in part one of an important article I think everyone should read, specifically on your blog. So it seems like Anthony Fauci was for some time there seemed to be a one-note Johnny over treatment options for coronavirus. And you raised the issue about why is it that he seems to be absolutely, hell-bent on making sure that there's, what did he say, randomized, double-blinded, placebo-controlled clinical trials for hydroxychloroquine used in this setting. Can you tell us a little bit about hydroxychloroquine, how it's been used, how you've used it, and whether you think that he has a double standard for, the degree of clinical evidence necessary to use hydroxychloroquine versus vaccines?
Sure. So in the United States, and I think in most other countries, the way doctors practice medicine, and at least in the United States, the FDA approves medications based on an indication, usually one indication or maybe a very small number of an indication is a reason to use the drug. It's a reason for which the drug has shown itself to be of more benefit than harm. There's an assumption that every drug has a potential for harm. Any drug label has a large laundry list of all the potential side effects that may occur. And then there are additional lists of the drug interactions that any drug will have with other drugs or may have with other drugs a patient is taking. So given all that, the FDA makes a risk-benefit determination that for whatever the indication, if it's a sore throat, there should not be very much risk because sore throat is very rarely going to kill you. So it should be a very safe drug. And for a drug like cancer, the FDA will accept a much higher degree of risk because the cancer is likely to help you. And even if the drug only gives you another month or two of life, that's considered valuable in determining whether the drug gets a license. Now, once a drug is licensed, a doctor can use it for any indication, any symptom or disease. But the doctor is bound by their professional role. So they can't. So if I prescribe a drug for which there is no published evidence for your condition and you become ill, you can sue me for malpractice. But if that drug is being used for that condition by many other doctors, you can't sue me, even if that is not an indication, because I'm practicing according to the established standard. I know a lot of people don't know these details, but they're important because drug companies and doctors go by the law as well as what they've learned in medicine, and they know what they can do and what they can't do, and what the law supports them on, and what could lead them to a lawsuit. So
Hmm.
having said all that, I have prescribed hydroxychloroquine widely for 20 years, 21 years, since I came across the work of Sam Donta, who used it for Lyme disease. I live in the state with the highest per capita rate of Lyme disease in the country, and my county has the highest per capita rate in the state. So we have a lot of Lyme disease. And Sam actually did a clinical trial about 25 years ago and showed that hydroxychloroquine, in conjunction with a macrolide antibiotic, and one macrolide antibiotic is azithromycin, was very effective at treating Lyme. So I have used it for that indication. I also have patients who've taken it for rheumatoid arthritis and for lupus. It's used to be a big drug for rheumatoid arthritis. Now there are other drugs that are considered better initially, but for rheumatoid arthritis, for lupus, it's usually the first line drug that is used. I also had my own personal experience with chloroquine, which is almost the same drug. It's the drug without the hydroxyl on it. I used that for almost a year while I traveled through Africa and India 45 years ago.
Hmm.
So, so I feel, very comfortable with this drug. I've given it to probably 150 or 200 patients. And to my knowledge, there is a significant ophthalmic toxicity if the drug is given for a while. So if I use it for more than a month, I usually have patients have an eye doctor check them to make sure that they're not developing any retinal toxicity, although my local retina guy tells me if the dose is low, they don't develop that problem either. In any event, it's a drug I'm comfortable with. So I'm talking about chloroquine and hydroxychloroquine as if they are the same drug, because they are almost the same drug. Hydroxychloroquine is considered a bit safer than chloroquine. I also actually overdosed myself with chloroquine once before I was a doctor. I developed malaria after I got home, and it was Christmas, and nobody wanted to treat me. And so I took an extra large dose of chloroquine and got over the malaria. It worked beautifully, but got synchronism, a well-known, well-described side effect, had ringing in my ears as if I had taken too much aspirin. So I'm familiar with that side effect. This was a drug that required a prescription in the United States, very cheap, easy to use, and there's a lot of people who've been on it for years because there's a lot of people with lupus and rheumatoid arthritis
Sure.
and people with Lyme. So there's probably, at least 1 million Americans that have had a year or more experience with the drug. In France, it was an over-the-counter drug until a few months ago. And in much of the third world, it is an over-the-counter drug. So not considered safe enough that a doctor does not need to prescribe it. You can buy it off the shelf in a pharmacy. And used widely, routinely, year after year by people who live in malarial areas when the malaria parasite is sensitive to chloroquine. Many of them are no longer sensitive, but some are. So still used for that. Okay, so here's a drug that was found by the Chinese to have some efficacy. I mean, we don't know how much, but the Chinese have recommended it in their guidelines as a first-line treatment for COVID-19, which is the name of the disease caused by SARS-CoV-2, the virus. And so people in the West started using it when we had cases, and reports are favorable. Certainly, although I'm completely unable to assess how efficacious it is, it seems that the reports all suggest it is better than nothing. So many doctors have recommended using it. There's a famous doctor in France. He's actually really famous. He's more famous than Tony Fauci in the United States is in France, I think, because he has discovered more microorganisms than any other doctor alive. He, um, there were old diseases for which it was thought they might be infectious, but we never knew what caused them. He's discovered the cause. He's very well known for his rickettsia work and for Bartonella in particular, and has discovered over, I think I said 100 microorganisms, and has published over 2,700 academic papers. So he's well known. He's iconoclastic. He has long hair. He says whatever he thinks, and I don't think he ever dreamed that people would start coming down, piling on him for prescribing what was until recently an over-the-counter drug for a lethal disease. But that's what happened. So wonders never cease.
Yeah, absolutely. So, looking at the landscape here, I've been following the COVID-19 outbreak and the virus since late January. The Chinese definitely used hydroxychloroquine. They definitely have that consensus statement, but they also, had done very severe, strict social distancing in addition to treatments. And so when they also used traditional Chinese medicines, they used other approaches and so on. But
Yes.
the first thing that I did, Meryl, was I did some modeling that actually was based on the R naught of COVID, SARS-CoV-2, and other characteristics such as the 4 to 5 day symptomatic period that we know about. And the determination that I came to was social distancing alone will simply cause a persistent infection to circulate throughout the population, but social distancing plus prophylactic therapeutics, and that's what you're talking about. You're talking about hydroxychloroquine not only as treatment, but you took it prophylactically. That in that prophylactic setting, my models tell me that it would shut it down with 60% social distancing and prophylactic use of 60% of the population, or something that is 60% efficacious used on 100% of the population, it would shut it down in 2 or 3 weeks. And this is independent of any testing. And all these factors and variables are interrelated, contact tracing and so on. But this was, I was equally stunned. I wanted to say that, when I saw Tony Fauci coming out and saying, nobody really knows about this drug. I'm looking at the millions. It's been around forever. It's been around and used, by our
Yes.
military. It's been around forever.
Yes.
And so for him to do that really did betray that he had an agenda to make room, I think, in the clinical outcome landscape for a need for a vaccine. In fact, there's a video of him stating, we don't want a lot of people to develop natural immunity to this. We don't want a lot of people to recover, right? Because that means that then we'll have people walking around with antibodies. We could use convalescent plasma therapy, he seems hell bent on making sure that a hallmark of his career is that he's the guy that brought forward a vaccine for the common cold. Does that resonate with your understanding of potential motivations? I mean, why do you think he's doing that? Why do you think he is against hydroxychloroquine?
James, I have searched to understand his reasoning, but I'm not going to attribute any particular reasoning to him. I don't think we should call this the common cold. It's a highly lethal disease. It is a disease that can be transmitted via aerosol. There is currently no approved drug, no approved vaccine. That would put it at the highest level of select agent as defined by the CDC that would be allowed only to be studied in BSL-3 or BSL-4 biosafety level 3 or 4 very high containment laboratories. The agents like that are highly infectious. So like Ebola, for example, anthrax is not highly infectious, but anthrax is another organism that is supposed to be studied only in biosafety level 3 laboratories. So this is basically the second iteration of SARS. SARS killed thousands of people and fortunately was less infectious, less contagious, and was able to be contained. Although there were a couple of lab leakages of SARS in Beijing subsequent to the 2002-2003 outbreak. And so some small number of more people died then. So this is not the common cold, even though both are coronaviruses. It's of interest that we have never been able to produce a coronavirus vaccine, either for the common cold, nor for SARS, nor for MERS, despite the fact I recently learned that there are animal models for these diseases. So the fact that years were spent trying to develop vaccines for coronaviruses suggests that it may not be so easy to do it this time around. Now, in terms of Fauci, Fauci has funded, the NIAID, which he directs, has funded the clinical trial of the Moderna messenger RNA vaccine, the first one out the gate. And so if that vaccine is successful, his institute will likely benefit financially. He is also a member of organizations created by the Bill and Melinda Gates Foundation that are designed to increase the number of vaccines available and vaccine uptake. So he has a longstanding commitment to vaccines as the perhaps primary therapeutic for dealing with diseases in general in the world, other than degenerative diseases. Now, whether these explain his recalcitrance to accept the use of chloroquine and hydroxychloroquine, I don't think they're sufficient to explain it. He's a physician. I mean, the things I told you about the way drugs are used, he is well aware of, and he knows that this drug can be safely used, and he knows that it can be used off-label, and he knows that it has a license, it has a label, its safety has been established. It does not require clinical trials.
Right.
When people are sick, you give them the drug that may benefit them. As you said, either prophylactically or as treatment, and this drug may do both. There are now starting clinical trials with prophylaxis in New York, and apparently India is prophylaxing some healthcare workers to see whether the drug works prophylactically to prevent this condition. And if it does, then we have a solution. If it's very highly effective, we will have a highly effective solution to the mess we're in, where there's no other easy way out.
Absolutely. So thank you for distinguishing between the COVID-19 and the common cold. Absolutely, they're two different diseases. The SARS-CoV-2 virus, it's a relative of the SARS virus. Though they both are beta coronaviruses, and MERS is also a beta coronavirus. I understand. I want the listeners to understand that when I was saying that maybe it's about his legacy, because if you crack the code for a vaccine for SARS or MERS or any other coronavirus, you've cracked the code for the common cold. You have done it. I mean, if they can make an mRNA vaccine, if they could make a protein-based vaccine, whether it involves a spike protein or not, the translational research that would be done that would be successful there would then transfer over to the common cold. So I didn't mean to imply that I think that SARS-CoV-2 is a common cold. And I agree with you, by the way, about it's a significant disease. The 6.3% mortality risk in people with diabetes, the 20% case fatality rate in people of a certain age. And there's a lot of misinformation going around over that it's not a serious illness because people are confusing the population death rate during an outbreak with the eventual population death rate or the eventual the current case fatality rate. I agree with you also that we did not. I read in your article you said that we're not really able to learn as well as we could from what the Chinese learned. It seems over and over again, at least in the United States, especially since they paused for a moment before they didn't adopt the test that was readily available from Germany. They had to make their own test at the CDC. They paused for a moment because it's almost as though they had to make sure, and when I say they, I hate talking about they in general, but the people involved in, the regulatory agencies that are also involved in the science here, they wanted to be sure that every piece of information that came about was derived from research that was based in the United States, as if they have no point of reference whatsoever to be able to have faith or confidence in what's coming out of China. And to some extent, given that the communist Chinese Communist Party does perform misinformation campaigns like our government does as well, there's reason for skepticism, but it always seems to lead to where the regulatory agency involved is then, it's as though they start from scratch. They're not able to transfer knowledge that other countries have gleaned. So when I'm talking about Anthony Fauci's motives, he is old enough to the point where I think he is going to be searching for what his legacy is going to be, right? People of a certain type, of a certain age, start wondering what their final legacy is going to be. And I've been, like you, highly circumspect, but also extremely critical of his handling of this, especially in not immediately promoting treatments, prophylactic treatments, convalescent plasma therapy, and the like. And I want to ask you further, given your expertise in medicine, about the mortality rates, and get into it a little bit, because there's a lot of people who are convinced that this is not a very serious disease. So, if you don't mind, could you break it down for us in terms of numbers and percentages of your understanding now? I understand that your article was written on April 11th, but could you break us down a little bit in detail here for us, what you think is going on now?
Jack, can I get back to Dr. Fauci for a sec?
Yeah, sure.
I was surprised to look at some of the coronavirus papers and find out that NIAID, the institute he directs, has spent hundreds of millions of dollars on coronavirus research, up to a max of $51 million a year at one point. And so you have this man who seems to be a public health guy speaking, in a politically correct way to an audience, but he never lets you have a glimmer of the fact that his agency has spent hundreds of millions of dollars researching these bugs, the coronaviruses, and he knows a lot about them. And a lot of the research has been done in conjunction with China and with Europeans and with Australians. And much of this research has involved the transfer of virulence factors between different coronaviruses. So it is certainly possible that research funded by Tony Fauci's institute has helped lead to the creation of the current coronavirus that is infecting the world. And I think the fact that he hasn't said a word about the fact that he knows anything about coronaviruses is itself of interest.
Right. So let's talk about the artificial origin hypothesis for this. So I was the first person to state that this might have been, that I know of, that this might have been a lab-created virus, and I stated it on Highwire based on similarity of an unknown part of the genome that was published by the Chinese team. Another team, an independent team led by a Greek researcher, reanalyzed the sequence data and said, yes, there's an unknown part. We don't know where it came from. So I used BLAST and NCBI's resources, and I searched for that. And I found that it matched nicely to a P-shuttle SN vector technology. I've since then tested the hypothesis in earnest with a report that's available on the IPAK website, where there's a protein motif signature that is characteristic of at least the spike protein that tells me that this was available, this spike protein, at least the precursor to the spike protein, was existed was sampled by science, but they didn't know that it was different from SARS because it was labeled SARS, and our researchers who studied their sequences didn't know that it was different from SARS. They had the same protein motif signature, and so I don't see any positive evidence in the sequence level anyway that it's a chimeric. All of the chimeric sequences that I know of that I could get my hands on don't have the characteristic protein motif structure. And other people that have analyzed the full genome sequence don't see the commonalities that are statistically significant matches and so on. The HIV subsequences that are present, they don't have a significant e-value for blast. That means that they're not necessarily there by anything other than by chance in terms of the match. But importantly, they also match things like plants and fungus, and so that paper was retracted by the Indian team. So I've spent about 3 weeks of intense deep dive trying to find positive evidence to say yes, this looks like it could have been. Now I'm not saying I know 100% that it's not, but I did flip quite significantly against that.
Yeah. Sorry, let me get this to the camera.
Bring it
Can
up
you see,
closer so we can see it.
have you looked at this?
I have, and in fact, I looked at that's receptor usage. Absolutely, there are chimeric sequences that are being studied in labs around the world, including the United States. The receptors that they're talking about, those protein sequences, I don't have anything to say about the receptors. What I'm saying is that the actual spike protein present in SARS-CoV-2 is unique to SARS-CoV-2. It is unique to an ancestral form of SARS-CoV-2 that we had in 2005. It's been
Mm-hmm.
around since 2005. And
Right.
so they've been doing chimeric studies for gain of function studies to try to see if they could understand more about how the virus enters cells and all the rest. And also Ralph Barrick working with the U.S. military and the Nanjing Command and all of that doesn't make it look like doesn't make it look very innocent. I'm taking this as if we were in a court of law where I was a jurist and I had to say, do I have sufficient evidence that's a smoking gun evidence that this is a chimeric virus? I can't rely on circumstantial
No,
evidence that
no,
they're
no. We don't have
yeah,
that.
yeah.
We don't have that. I don't get me wrong, but what we do have is evidence that many chimeras were created, and
Yep,
that of those that were created, they did take pieces from different known coronaviruses,
yep.
and that the reason I showed you that before, because I don't know what a virus-based pseudovirus system is, but they used an HIV virus-based pseudovirus system, and I wondered if that would include that HIV sequence you thought you saw.
Well, I didn't see it. The Indian team saw it. There were 4 subsequences, and they were very, very short, which means that they matched HIV. It could have
Good.
just been by chance. I mean, I'm talking like I think there was less than they encoded less than 6 or 8 amino acids. They're very, very
Oh,
short, Meryl. So it's a
oh,
right, and that's why they didn't have a significant e value. Are they messing around with viruses? Yes. So for people that are new to the broadcast, I've talked about this before, but Ralph Barrick and his colleagues downloaded a sequence from China in addition to 3 other sequences, and they calculated what's called a consensus sequence, and then they reconstructed that synthetic virus by creating the consensus sequence of those 3+1 sequences. They had no idea that one of the sequences had a SARS-CoV-2 spike protein. But it
mhm.
does. If you go back in the old sequence, you can see it encodes the SARS-CoV-2. Had they known it was SARS-CoV-2, they wouldn't know that they were potentially creating in the lab a virus that had different parts by mathematically calculating the consensus, which is different than what you're talking about. But I'll get to my point that in calculating that consensus, it reveals what they did not know. They thought they had another SARS, a run-of-the-mill SARS. In fact, they thought they had 4 run-of-the-mill SARS. When they calculated the consensus sequence, they would have left that odd one out if they knew it was a functionally different. So at that time in 2005, 2008 was when Ralph Barrick's team did it. And because they didn't know that it was there, and it was there already, it's not like somebody tinkered with it since 2005 to create this. So if it was created before 2005. And knowing the outlay of technology and what people were doing at the time, I'm very skeptical that it could have happened. Now, since then, yeah, they've been bringing all different parts of all different kinds of viruses all together, and those gain of function studies actually had a moratorium, except for Ralph Barrick's lab, who got grandfathered in because he was working with the military. Okay, then
Yeah.
they lifted the moratorium, and I think we ought to go back to the moratorium on gain of function studies. Ralph Barrick specifically, in that study in 2008, had to add a piece of DNA from another virus to make it able to be to make it able to infect mouse tissue. So yeah, they're doing all kinds of Lego block building in the lab with viruses, and I think it needs to stop. But I can't find any positive evidence that this one is it. So I think it's been around. I think it's an older. If you understand evolutionary biology, so I think it's an older virus that is so lethal that it probably came into the human population multiple times, but simply killed those people due to pneumonia, and it wasn't yet transmissible. Somewhere along the way, it picked up this weird transmissibility, and
Well,
evolution.
you're making some assumptions. The thing is that coronaviruses do recombine naturally.
Absolutely,
That's what,
absolutely, 100%.
so if you have more than one coronavirus in an organism or in a tissue culture, you're likely to get new recombinants that
100.
may have,
Yep.
okay? And of these different coronaviruses that were looked at, some were MERS, some were MERS-like. There were over 40 of them altogether. And so it makes perfect sense that when you're recombining characteristics from known highly dangerous BSL-3 and BSL-4 level organisms, select agents, that you certainly could wind up with with organisms that have more virulent characteristics, such as more transmissibility,
Yep.
or more stability in the environment, or more tissue tropism. That means they will infect more organs than the original.
This one
And we
certainly
seem to
does.
be
Yeah.
finding this particular bug has all three of those characteristics, as opposed to the SARS it allegedly may have derived from or may not have derived from. So whether anybody intended to create such a virulent organism, I mean, here it is. And the kinds of research that were being done certainly opened Pandora's box to make such a chimera potentially to be created. And I do not think it was used by anyone by any entity that would have created it as a deliberate bioweapon. I don't believe that at all, because one thing I know about is how bioweapons have been used in the past, and they've been used in a careful manner as weapons only to be used on the enemy and not to blow back to your own people. And this one is completely uncontrollable. I feel strongly that it wasn't deliberately released by a government or a laboratory, but I do feel that there's a reasonable, we have a trail of 7,500 or more research papers on coronaviruses over the last 17 years to show us that things like this certainly could have been made using the types of methods and the types of experiments that have been published, that we know existed both in the United States, in China, and in other countries, and supported by NIAID, Fauci's organization, USAID, Australia, the European Commission, and many different institutes in China.
Japan did recombination research. The European countries did it. Australia, United States, China. There's nothing that you said that I disagree with. Every time that there's the natural biology of the coronavirus requires recombination, because there's only partial transcription for there's dual transcription, there's a polyprotein and so on. So you end up with multiple mRNA products that then the proteins are reassembled into this chimeric virus. 100% agree. And so I agree with you. there's no evidence that it's a bioweapon in a policy level either. It's a stupid thing to do to create a virus like this that's going to blow back. I agree with that. What I'm saying is that I scoured and followed the transmission from lab to lab through phylogenetics. I did genetic epidemiology on the phylogenetics of the chimeric viruses, of the natural viruses, and so on. And as far as I looked into it for the spike protein, that spike protein does not look like it's a Frankenstein protein. It looks like the ancestral. And I'm actually the most likely scenario for me as an evolutionary biologist is that SARS is a weakened form of SARS-CoV-2. That SARS-CoV-2 existing in nature probably came into the into the human population hundreds or thousands of times, killing every person that it ran into. And that's why we never see it. But we saw SARS first because it was adapting to the human immune system and so on. It was less lethal. And I have a peer-reviewed publication that I may have sent you on pathogenic priming as being one of the characteristics, and the proteins that are coded by this virus that match human proteins and could cause autoimmunity are distributed in many, many different tissues. And so we totally expect some kind, especially the long duration of this infection. It's very unusual that you got the 4 to 5 day asymptomatic period. You've got 18 days until you get really seriously ill in some cases. And then apparently you're still shedding this thing for quite a period of time in the feces afterwards. That's a long time for an active virus to be in any immune system. And third of the proteins, Meryl, that we may be seeing autoimmunity in are human immune proteins. So if this causes an impairment of the immune system by autoimmunity through biomimicry, not biomimicry, but molecular mimicry, this may explain a huge part of the pathophysiology. I really love talking about this with you because it's 100% correct that we absolutely expect something bad to happen. It's like Fukushima, right? It's like Chernobyl. What's the probability we're going to have a nuclear incident at a nuclear reactor on the Earth? Well, it's already proven to be 1. The probability is 1. It's happened. So what's the probability we keep messing around in the lab?
Had Ukraine.
What's the probability we keep messing around in the lab with these viruses that we're going to get a Frankenstein virus that does much more serious damage than SARS-CoV-2? I think the probability is 1. We'll get there eventually. I agree with you. I'm just wanting, the level of evidence that I need to say, aha, I did the you check the pedigree of the viruses. They're definitely related. SARS-CoV-2 is definitely a beta coronavirus. I can't put my finger on any exact component of the virus that says this and this, clobble it together. My most likely scenario is that somebody was infected with a SARS-CoV-2 like virus from a bat, and that they also then got in contact with somebody that had a SARS infection, and then it recombined in either or both.
Well, sure. I mean, there are many theoretical,
scenarios,
ways might have happened
after an accidental laboratory release, because there were 7 accidental releases of SARS in 10 years, which led to the moratorium. Yeah. It's 100% that we're going to see accidental releases over there. So
we're here,
right?
So that's true, but that doesn't mean that the probability increases when you're in a lab that's creating coronavirus chimeras. Yeah. And the other thing, you've sort of got an implicit assumption that you have seen all the, that people have submitted to gene banks the sequences of all the organisms they've worked on. But I would submit that when you have a military program that works on these things, you do not submit all your organisms to gene banks.
I couldn't agree more. That's why I called for more transparency, that we need them to bring forward all laboratories that have coronavirus tissue coronavirus samples or the data. They need to sequence or they need to publish all the sequence data that we have. Taxon sampling and phylogenetics can actually influence your result that you get from your phylogenetic tree. So the more dense taxon sampling we have around coronavirus 2, bat-like coronaviruses, the more accurate the phylogenetic tree should be. And I absolutely am not saying I know it's not a bioweapon. What I'm saying is that the evidence is stacking up against it, and that could change. If somebody could find a sequence in a lab that's a 100% match or a 99.999% match, and then we can
Well, you
say
could never
this is where it
find
came
the
from.
sequence in the lab because they've all been destroyed when this
Exactly,
happened.
exactly. But some, maybe I'm just saying, somebody could find it in the lab. There's multiple labs, as you know, in China. So maybe the smoking gun sequence was destroyed in the Wuhan Institute for Virology when the Nanjing Command took over. Possibly, I understand they got in there and they said to destroy. But it's possible that they might have shared that very sample out 2 weeks before to some other lab in China. So I mean, to do other research. So it's all there's so many smoke and mirrors here. There's so much intrigue with the Harvard medical researcher, guilty of trying to transport vials of viruses to China. There was a suspicion over Dr. Shi and her role in this. And I think I've just we've talked this one through. I think I'm
Yeah.
almost certain that it's not created in the lab, but I'm equally almost certain that it escaped from the lab.
Okay,
At
so
Wuhan.
well, then you just said something that was opposite to what you said, which is you think it wasn't created in a lab, but it escaped from a lab. Well, it had to be in a lab in order to escape. So I think what you meant was it wasn't created as a deliberate biological weapon in a lab, but it probably did come to its life in a lab. I
Yeah,
mean,
yeah. I mean, if you want to, if I'm talking about artificial biological intentional origin is unlikely. That's not lab created. But if somebody cleaning a
no,
cage, if someone cleaning a cage, which is these are the people that end up getting infected in these BSL or 3 and 4 labs. If somebody cleaning a cage cleaned a cage of a bat that was infected with a natural virus, that's a natural source. That's not, it's lab origin, but not lab created. So I know it's confusing, but you know,
well, actually, I do know of several people who died at Fort Detrick who were researchers, as well as the electrician who came in to change the light bulb in the anthrax lab.
wow,
So I would say that just be careful about the assumptions. I think that when you're doing work and creating recombinants, you do not know what you're going to get in the end. And
absolutely.
so it may well have been something that was created in a lab inadvertently, may not have even been identified, and then could have gotten out inadvertently as well.
Yeah, absolutely. So let's say that they were doing another scenario is that they brought in a sequence from the wild and they transfected it into, say, mouse tissue, human tissue, or living mouse or other animals. And then in the lab, there was some, evolutionary event in the lab without intention, but evolutionary changes became more transmissible, longer latency period and so on. Those things are all possible. There's not even possible, they're plausible that you're going to see that happen. Of course, every time you put a new pathogen, a pathogen from the wild into the lab, it acclimates to whatever tissue you're growing it in. That happens. And
Right,
right. And
right.
so certainly that's all plausible. Anyway, so this mortality rate issue I brought up earlier, that's a real problem because,
That's a
I have
problem.
yeah, I did a deep dive into the statistics that the CDC's been using on influenza. In 2014, they separated out influenza from pneumonia. In 2015,
Mhm,
going forward, they combined influenza and pneumonia, and they
mhm.
called it influenza disease. And that's where we get these large numbers, like 55,000 or 60,000 numbers deaths from the flu. And when
Yes.
people, go ahead.
Okay, so the whole question of how many people die from influenza every year in the United States is unknown. There depends how you calculate it. So the CDC doesn't well, they do calculate it. They don't actually measure it. They have an algorithm that they don't share with the public, and they predict it, and we don't know what they throw into that algorithm. So their numbers of 40 to 80,000 deaths a year from flu are completely, a fantasy.
Yeah.
If you look at death certificates, which I have, most years there are 1 to 2,000 Americans per year on whose death certificate influenza is listed as the cause of death.
Mm-hmm.
We had a very bad flu year. It was about the worst in 10 or 20 years in 2017-18. And I searched, it was hard to find, but I found the number of deaths on death certificates from flu that year. And it was 6,050 something. So I don't know how many people die of flu each year in the United States, but I am guessing it is somewhere between 5,000 and 10 or 20,000.
Yeah,
Now,
absolutely.
there are a lot of people with many comorbid conditions, particularly people in nursing homes, because as a physician, I've been a hospital physician for more than 10 years of my career. Actually, and I was so in the hospital, inpatient, and then I was also an ER doctor for about another 10 years. And I can tell you that almost nobody in the hospital dies of influenza. So, it would be, I can't even remember when a patient I treated died from influenza. But in nursing homes, people are dying all the time, and they have a lot of conditions, and they're old, and then they get influenza, and then they die. And I don't know what their doctor, their death certificate. I don't know if they are sampled, if anyone sticks a swab in their nose or their throat.
Right.
Most people in nursing homes are given yearly influenza inoculations, which have not been shown in the nursing home population to benefit them, to stop hospitalizations or flu mortality. The vaccines probably do help a younger age group. Neither have vaccines given to the staff in nursing homes been shown to reduce mortality or hospitalizations in the residents of those homes.
Absolutely. Thank you for that. So in 2000, back in 2014, there were, I think, 55,000 deaths total between influenza and pneumonia, but only 8.1%, about 4,500, were attributed by CDC to influenza deaths. And so going forward, then, if we say that it's somewhere around 8.1% or around there, then if we look at 66,000 or the worst case scenario and so on, we're left not being able to make a comparison of the number of deaths that we're seeing from coronavirus to influenza. To influenza, because they combined pneumonia from other causes, including pneumonia from coronavirus. So it would be
Right.
really important, I think, for health freedom groups around the country, and I've been saying this for some time, to pass legislation that requires cadaver sampling to determine if there's been respiratory virus involvement, that to determine what respiratory virus was involved, that we need actual data as opposed to this weird kind of arm waving flu syndrome or flu disease. And the CDCs have caught not knowing what to do, because I contended on my LinkedIn article that they're cooking the books on influenza to amplify it so they get above the 7 point whatever percent they need to call it an epidemic. And now that coronavirus is taking kind of its share of those deaths, the proportion due to real flu is going to drop precipitously, and that means they're going to lose epidemic status for flu, but they have this massive new epidemic without a vaccine. And so if they're trying to mandate vaccines for everyone, regardless of choice, on the basis of, well, influenza kills $55,000 a year, they kind of lost the gambit on that, don't you think?
It's a complicated question. First of all, flu generally is over by the 1st of April. So right now, virtually all the flu-like deaths are going to be coronavirus. And I think we should be sampling them, but we have no idea what the availability of tests are in different places, nor what their sensitivity and specificity are. So we're blind in multiple ways in terms of testing. We would like to know a lot. I don't know why. It's inconceivable to me that we have screwed the testing up this badly. And I hope somebody will explain it. There was something else I was going to say. So very few people get autopsies now because nobody wants to pay for an autopsy. Insurance doesn't want to pay for it. Family doesn't want to pay for it. And the state doesn't want to pay for it. So autopsies are extremely rare, only if there's a very curious cause of death. And I've asked doctors when a patient I knew died and wasn't expected to die to do an autopsy, and the medical examiner, in which case, so if the medical examiner takes the case, that means the state will pay for it, and the state medical examiner will be responsible. And anyway, that is not being done. The burden on the medical examiners from all these drug overdose deaths that we've had in the last 10 years has, kind of wiped out resources at the medical examiner level. So I think that rather than asking for autopsy data and using swabs that are done for flu to, figure out whether you can PCR them for coronavirus, or, using some other method might be more valuable.
Yeah, that's
I
exactly what
believe,
I'm suggesting. That's precisely what I'm saying. It's just to swab the cadaver, not a full autopsy. Absolutely.
yeah, and
100%. I think,
but who has authority to do that? That's another thing. Once someone's died, their body belongs to their relatives,
yeah,
so you have
absolutely.
to ask permission.
Yeah, well, absolutely.
But while they're alive, if they want their throat swab for something else, you can probably come up with a protocol to be approved to test that swab for other things.
Well, if I had an aging parent and the parent died of respiratory illness, and they said to me, listen, they were in a nursing home and they died. We'd like to determine if it was flu or coronavirus. Would you give us permission? Yeah, I might want to know. Certainly want to know. And that's
Absolutely.
me. Other people might decide differently. But from those data, those data would still be incredibly valuable. Even if it was 25% of people that said yes, or 10%, it would be incredibly valuable to know the proportion of people dying in nursing
Absolutely.
homes,
It
right?
would be tremendously valuable. As soon as you say the patient has died, insurance is not going to pay for that test. So who's going to pay for it?
Well,
You
this
have
would
to
be
say the government has to come over. The government has to say we're going to pay for all the corona
exactly,
tests, dead or
exactly.
alive.
Exactly, and that's what I'm saying. That the health freedom groups, if they said that this should be a standard policy, standard practice, so if the state's going to make base policies that we all have to get a flu vaccine because there's 55,000 cases of flu that lead to death every year, and they can't even get that number right, then let's go the opposite direction in the future and make sure that we have exact data so that we know exactly what the third most leading cause of death is. It's not flu, right? Or whatever. Whatever the seven. You have to kill 7% of people if you're a cause to be an epidemic. So I'm not even sure coronavirus will reach that once it's all said and done, because that's out of all deaths. It's not a 7% death rate. It's out of all the deaths. It's a stupid way to calculate whether you have an epidemic, right? if you say you need 7.3% of all deaths that occur in a given year for something to be called an epidemic, then the minute you have something that has a really, really high death rate, all the rest of the things are no longer epidemics. It's all relativistic,
Wait,
and
whose definition is that?
that's the CD. Yeah,
7.3%.
that's the CDC's definition. I'll send you the reference. It's on the website. Yeah,
Thanks.
and and you're exactly right. You said something earlier about the test. I did a deep dive on the test, and I have an episode of this podcast called "Ending the Pandemic" about CDC's deadly testing fiasco. What they had done was they instead of adopting the World Health Organization's recommended test from Germany, which did a beautiful validation study before they started using it. The German scientists did a fantastic job. They showed it had 100% pathogen specificity. They showed that it had over 90 something percent sensitivity in negative, asymptomatic sputum samples that they were asymptomatic sputum samples that had been spiked with SARS-CoV-2 mRNA. So it was basically a series of positive controls. And then they brought in a whole bunch of people that had other illnesses.
Mhm.
And so they found 100% pathogen specificity. And finally, they did this test where it was, on the negative sputum samples without any symptoms. They couldn't find any SARS-CoV-2. It was as good as they could do, just given a download of digital information.
Mhm.
And so the CDC said, no, we need to make our own. And when they made their own, they actually made a mistake on a pair of the primer sets. It
Yes.
failed, and they sent this test out, and it was used on hundreds or thousands of people before those other medical, physicians conducting the test said, yeah, but I know that this is a COVID test. The test must be wrong. So they created their own test locally. They ran their own PCR test locally. That's how trivial it is to make a PCR test, by the way. You just need the genome sequence. And they said, no, your test is messed up. CDC subsequently said, just ignore that third set. They had 2 out of 3 primer probe sets. But I've never seen sensitivity or specificity statistics at all from CDC's test, and they're the people that are supposed to validate everybody else's test. So this is a major, major mess up, and I'm flummoxed and flabbergasted as well. Um, so doctors around the world are talking to each other. You say, but strategies to improve survival are limited. You asked about 2/3 who were placed on ventilators do not come off alive. Is that because the tissue in the alveolar sacs becomes so weakened that there's real serious tissue damage that they can't handle the pressure? That's what I've been told, that the lung tissue can't handle the pressure.
Okay, so you can set a ventilator any way you want. Um, but there were standards for the way you were supposed to optimize your ventilator settings in ARDS. And it seems, again, I have not taken care of these patients, I'm just reading, but it seems that the optimal standard ARDS protocol, it was not optimized for many of the COVID patients. And so the pressures that were being used were too high and the volumes were too low. And now people are playing with that and maybe there's 2 different sets of COVID patients. Maybe this group needs this sort of ventilator settings and that group needs another. And, have to say, because I'm old school, I'm really, really old school. And, I had patients on ventilators, many decades ago. We didn't use protocols. Like, why the hell would you use a protocol? You look at what works in this patient. I mean, you know what
Mhm.
pressures are going to be too high. You know what volumes are too high. You know what range you can, put these settings at. And then you look at the patient. And if they're not doing well, you change it. And if they're not, and you adjust it. And that's what I did with a ventilator for many years. And apparently that isn't what's done anymore. You set it and you walk away. And all right. Having said that, still, this is a dreadful disease to the lungs, and many people, some people were having damage from pressure and damaging alveoli, but many others were going into a state after they've been on the ventilator a long time of scarring down their lungs. So they have fibrosis and they don't have a lung that will move. And
And that's through the matrix
while
restructuring,
that
right?
was and that's the nature of the if you have the autoimmune surge, the
Yeah.
cytokine storm, you have too much of that. Um, it's also well known for many decades that the longer you stay on a ventilator, the less likely you are to come off of it, for a
Yeah.
variety of reasons. You're just ventilator associated illnesses like pneumonia. You can get, that you can soften the tissue of the trachea. You've lost muscle strength in your chest to move your ribs and take a breath yourself while the machine's been doing it for you. So, but there are things one can do again to ameliorate all that. Uh, but because that's known, people tried to get COVID patients off the ventilator as quickly as possible, and sometimes that was the problem. That it took a long time to get over this illness and get them off too fast. That can kill them. So I think right now doctors are playing with it. It's good that they've realized that initial protocols were not optimized, and we'll see what happens with that. But if you don't, my feeling is that if you don't get the viral load down early in the illness, why would you expect people to do well? Because you're giving the virus time to get into all these other organs and continue to cause damage. So some people, as they're ready to come off the ventilator, they go into heart failure or they have an arrhythmia, because their myocardium has been damaged by virus, or they're in kidney failure. So they're going, moving back to the hydroxychloroquine and chloroquine. If these are drugs that in fact kill viruses in vivo as well as in the test tube, which it's a good chance that they do kill some virus, if they're effective at that, then the earlier you insert them, the better. And let's compare that to other antiviral drugs we have. So if you have influenza, what's the antiviral? Tamiflu. When do you give Tamiflu? Tamiflu is only approved to be given in the first 48 hours of symptoms. It doesn't work after that.
Mm-hmm.
All right, what if you have herpes? Herpes simplex, valcyclovir, okay? Recommended for only the first 48 hours, otherwise it won't work. Herpes zoster, shingles, Famvir, first 48 hours. So why in heaven's name would you withhold an antiviral until people are in the hospital? You have to be insane to do that.
It looks like really bad advice. So speaking of the lung tissue damage, there's a few case reports of patients that had blood cancers that were on immunomodulatory drugs to calm down their
Yes.
immune system, and that they had severe COVID-19, but then when they took their dose of the antiviral, when it came, not antiviral, when it to the immunomodulatory drug, the COVID-19 symptoms went away, which is another kind of feather in the cap that this is a multi-systemic, multi-organ autoimmune condition. The kidney damage, the cardiac arrhythmias, and so on are consistent with that. So I agree. Anything that would lead to lower viral load, any antiviral, naturopathic, allopathic, pharmaceutical, whatever,
Exactly.
should be considered.
Yeah, if it's not going to kill you, and this disease might, it should definitely be considered and should be given to a subset of patients.
Absolutely. So I also had hydroxychloroquine or chloroquine, I forget which, to prophylactically when I had to travel to the tropics for my master's degree. So what's going on with guidelines and restrictions here on the drug itself? I mean, it seems to me, I know convalescent therapy, if you can use convalescent therapy if you do filing with the FDA, because they reclassified it as an IND of all things. Here we have convalescent plasma therapy has been around
Yeah.
forever, and now they reclassified it as an IND, basically a new drug. And so the doctors have to fill out paperwork. But if you have hundreds and hundreds of patients and you're trying to save their life with plasma convalescent therapy, you have survivors you collect the plasma from, and you treat them with it. That's a lot of paperwork to file. What's the current regulatory status in the United States for chloroquine and hydroxychloroquine? Do you know?
Well, at the national level, they're both licensed drugs. They require prescription. That's, nationally. I wrote a prescription, it was filled. At the state level, a whole lot of different things are happening, and I don't know what federal agency or federal person is driving this. But 23 states had a whole series of different restrictions which were imposed using a variety of different methods for prescribing these two drugs. So 27 states don't have any restriction, but 23 do. In New York, the restriction was imposed by 2 executive orders from Governor Cuomo. In New Jersey, the restriction was imposed through the Office of Consumer Affairs. I counted up of those 23 states how many were run by Republican and how many by Democrat governors, and it was 11 and 12. So it wasn't broken down on a party basis, and there must be somebody big in the federal government telling these states to do this, but I do not know what it is.
Are you able to find an association between restrictions on hydroxychloroquine and no restriction and per capita mortality by
No,
state?
no, no, we're not there yet. This is all very new. I also don't know whether there's enough of the drug or not. It doesn't take very much to treat you for this. It's supposed to be between 12 and 16 pills, and the pills are very cheap. And we know that there are tens of millions of them available. But if you have a country of 300 million, 330 million people, and they want to use it prophylactically, which is 2 pills a day per person or less for low, people, children,
Yeah.
um, we might run out, in a few days. So it would be nice if the government not only would tell us how many pills have been donated to the Strategic National Stockpile and made available to the feds, which will then give them to the states, but actually tell us how much of the precursor chemicals are available, at what rate these drugs can be produced, and whether it looks like they will be sufficient to meet global demand or some segment of global demand. I mean, that's the information to me that's really important, because if this is an issue of, we don't have enough, tell us that, and then we'll figure out who should get it. But right now, it's a very, very haphazard business.
Yeah, absolutely. My initial foray into this, I can't give you a reference for it, but somebody mentioned that it's incredibly easy to make and it's easy to ramp up the production of it. It has been that way for some time in the United States. Whether they have the reagents necessary is a great idea. So your anthrax vaccine blogspot.com, I'm going to post it in the comments of the video so that people can go read your article. You have a part two coming. What's part two going to focus on?
It's going to focus on all of the things that the government isn't and hasn't told us so that we are not enabled to make any sense of what we are going through and how to get out of it.
Yeah, absolutely. So that'll be a very interesting read, Meryl. So listen, if you send to me the names of the states with 23 and 27 that have restrictions and don't, I'll put a research team on getting, per capita mortality. We'll do an association analysis and we'll send you the results so that we can see
Yeah,
if there's a difference in that per infection, the case fatality rate.
yeah. But just because some states have restrictions, this is again, it's some states have a lot of COVID patients, some states have very few.
Per
We don't know
infection
how.
rate. Yeah. Hmm.
Yeah, yeah. But still, I mean, in New York, for example, I think hospitalized patients are getting it. Most probably hospitalized, but most non-hospitalized are not getting it. And so, as the rates of hospitalization change, I mean, this is a difficult thing to figure out.
I agree. You
Um,
said it beautifully in your blog article that the death rate lags, the serious illness lags for 3 to 4 weeks. There's this huge lag time. And I'm not one to hang my hat on during an epidemic, during an outbreak with exponential curves, what's going to happen tomorrow based on where the analysis is today. But, taking a snapshot right now, because governors are struggling with these policies. And I think it'd be useful to see if we can detect an association between worse health outcomes overall in a state. If we have higher survivorship, lower rates of severity, something like that. More information is always better, right? So I'll be happy to take a look at that.
Absolutely.
Yeah.
Oh, let me just say this too, that um, as of 9 days ago, the exponential curve where we were doubling deaths every 2 to 3 days has completely stopped. It has flattened. We are not doubling deaths, every 2 to 3 days. We're sort of at a plateau on deaths of about 1,500 to 2,000 a day in the US. So this is a good thing.
Yeah, it is a good thing. I detected that with my analysis. It's a great thing. It's a great reason cause for celebration. I detected that with my analysis of effective R naught, where I take the ratio of the number of cases today to the number of cases 5 days ago, and just plot that. It's a very simple statistic, and it seemed like we were definitely headed towards one. And I talked with David Brownstein, who you probably know, and he's very interested in teasing out, is this not because of the fact that we're coming into the summer, equinox, the
Mhm.
timing of the year, people getting more vitamin D and things like that. It would be fascinating to. I hope this has a seasonality. But I'm not sure that
Yeah,
we
we
do.
want yeah.
I certainly
I,
hope.
I
There's lots of countries in the tropical regions that seem to have the same kind of progression of the curves without, but that's
That's
another
right.
analysis too. So listen, I want to give you the last words. If you want to close out with anything new coming from you that people should pay attention to, where can they find you? What's going on with Meryl Nass these days?
Thanks. Yeah, my blog, as you said, is anthraxvaccine.blogspot.com, and I am trying to write about the issues that other people aren't writing about that are important for this epidemic. So thank you for inviting me,
You're
Jack.
welcome. It's a pleasure having you. When you write article number 2, let's have you back and we'll go over it this way. A lot of people said that they were very excited that you're going to talk to me about this. And so very, very honored again to have you on this and to get into these issues that we've gotten into. So, all right. So, ladies and gentlemen, that's Dr. Meryl Nass signing off. And we're in sorry about that, this technical things. We're in a really good position now, since you know to go to Meryl Nass's blog article to go for a medical, science based, evidence based perspective with a lifetime of experience in medicine, a lifetime of experience in standing up for reality and not just going with whatever's going to pay the bills, which is way too much is going on that way in society these days, especially around public health. The bad actors that we know that are out there that are biasing reality. Meryl is a clear-headed thinker. She's a brilliant mind, and I'm just so excited that we had her. We'll see you guys next time. Signing out. Till next time.